Pradeep Pendyala, Professor of Anesthesiology. Today I am going to discuss with you about supraclavicular block as well as the interscalene block. These are the two blocks which you do very often. I am sure you know the anterior rami of C5 to T1 form the brachial plexus. Okay, and the brachial plexus exits the cervical spine from the superior, middle and inferior trunks. Each trunk divides into anterior and posterior divisions, and it further forms the lateral, posterior and medial cords as it travels the clavicle. The supraclavicular approach blocks normally the brachial plexus from the distal trunks to the proximal cords. Before giving the supraclavicular plexus, I would request you to put the patient lie supine with the bed elevated to 30 to 40 degrees elevation. That would be better. And the patient should be positioned in such a way that the head is turned to the opposite side. The patient, when you have positioned well, the subclavian artery should be palpated. It is palpated just behind the midpoint of the clavicle. Okay, then you take a 50 millimeter and 22 gauge short bevel needle, and it should be inserted just lateral to the subclavian artery. I just mentioned subclavian artery is palpated just behind the midpoint of the clavicle. Okay, or else you take 1 inch lateral to the clavicular head of the sternocleidomastoid muscle. That's the point where the needle should be inserted. Needle can be inserted at the, if you have already felt interscalene groove, that is between anterior and middle scalene muscles, go to the bottom, lowermost part of the interscalene groove, and you can do the insertion and you will reach the supraclavicular block position. The needle is slowly advanced downwards and slightly medially. Okay, till you elicit paresthesia. Paresthesia is a funny sensation which the patient himself will say that, and you have to elicit it. You have to ask the patient, are they feeling the paresthesia or not? And there could be shoulder twitch. And if the shoulder twitch is there, that means the upper trunk has been stimulated. And if there are stimulations of the biceps, triceps or pectoralis, that means the middle trunk has been stimulated. And if there is flexion or extension of the hand, that means the lower trunk has been stimulated by the peripheral nerve block. Okay, the hand muscle response is considered ideal, as it indicates the lower trunk has been also involved, and that's the best point for giving the local anesthetics. Okay, the complications are very common, which you all know: pneumothorax, phrenic palsy, and arterial puncture of the subclavian artery. That could be dangerous. It can cause hematoma or intravascular injection. That would definitely cause LAS, local anesthetic systemic toxicity. Okay, and you have to avoid that. Coming to phrenic interscalene block, that is very essential. The position, as I had mentioned earlier, for the supraclavicular block, the patient should be put supine with the head end elevated to 30 to 45 degree. Always feel the lateral border of the sternocleidomastoid, and just still lateral phase, you find anterior scalene muscles. Still lateral and posterior, if you move your fingers, you get the middle scalene muscle. And in between, you can feel a groove, a valley between those two anterior middle scalene muscles. And exactly next to the cricoid cartilage level. What is cricoid cartilage level? C6. Okay, level. And Cheshire-Nax tubercle, and that is C6 transverse process. That's the place when if you can palpate it in this groove, interscalene groove, and if you feel the anterior border of the C6 transverse process, that's the place you should put the needle entry point. Again, 50 millimeter 22 gauge short bevel needle is inserted into the interscalene groove at the level, as I had mentioned, C6, that is cricoid cartilage level. Slowly progresses deep to feel the paresthesia and use peripheral nerve stimulation. The twitches would be definitely seen pectoral muscle, deltoid, triceps, biceps, forearm muscles, and hand muscles. If diaphragm twitches are seen, that means anterior and medial needle has been placed. So hence, you place the needle slightly posterior and lateral after reinsertion. Okay, and if neck contractions are seen, that means you need little replacement. You redirect it slightly posteriorly. Okay, and the scapular twitches would indicate stimulation on the dorsal scapular nerve. So you have to be very careful. Serratus nerve muscle contraction point towards long thoracic nerve stimulation. And you have to be very careful where exactly you are placing the needles. So that indicates posterior placement, and hence you have to redirect the needle slightly anteriorly. Always select a current around 0.5 milliamperes, and if there is contractions of the muscles even at 0.2, that means you have put the needle intraneural. Kindly withdraw the needle a little bit and then inject the local anesthetic solution. Contraindications, absolute contraindication, as usual, patient refusal or the infection at the local site. And if there is diaphragm problem and or a recurrent nerve palsy or respiratory disorders, already cardiorespiratory disorders of the patient, preferably avoids interscalene block. Okay, whenever you are doing interscalene block, there is always a problem, a small little part of the clavicle and the shoulder, skin is not properly blocked. For that, you need to give superficial cervical plexus block. It's very, very simple. As I had mentioned, the patient is placed the supine position with the head turned opposite side. Select the needle point exactly midpoint between the mastoid process and the sternal insertion of the sternocleidomastoid muscle, and give injection in a fan-shaped manner after negative aspiration. And be very careful because external jugular vein is very much at that place. Don't inject the drug in the external jugular vein. And once you have done these two, you have mastered the technique, and all the good luck. Thanks for patient listening. Have a wonderful day. I'm signing off today. Bye-bye. Take care.